Hey everyone, I'm so glad you're back to Growth Factor. You're looking at, I'm going to point, I think, in this direction, that direction. I don't know. Zoom always messes me up. But this is Dr. Thomas Seyfried. He's amazing. You can find him all over the internet, all over YouTube and many other apps. And he's basically here to tell us about cancer. There's so many myths, and a lot of us worry about it because we have friends or family that we lost to cancer. But the reason I do my show, I want to let you know why I invited the doctor professor here, is that I used to have anxiety really bad. I had doom feelings. It was probably depression. And if I can just take some of that off your plate, I'm looking for answers just like you are. So that's why I have the professor here. I'm going to tell you a little bit about him, but then more in the interview, I'm going to tell you more because he has such a huge resume. But I'm going to tell you first, he's a professor of biology at Boston College. He has his Ph.D. in genetics and biochemistry from the University of Illinois, Urbana in 1976. He did his undergrad work at the University of England, and he recently received a very distinguished award. It's called the Alumni Achievement Award. That's so incredible. He helped so many people. I'm so glad you're here to listen to him. He has his master's degree in genetics from Illinois State University in Normal, Illinois, and he served in the U.S. Army 1st Cavalry. He got a lot of medals and commendations. So I just want to read that to you because there's so much more to talk about. Can we start, please, with the cancer myth, Professor Dr. Seyfried?
Oh, thank you very much, Amalia. It's nice to be here on your program. Cancer myths. The biggest myth is cancer is a genetic disease. That's the singular biggest myth. It's not a genetic disease. It's a mitochondrial metabolic disease, which means basically that cancer originates from damage to an organelle in our cells called the mitochondria. They often call it the power plant of the cell because it makes most of the energy for all the cells in our body. So when that little organelle gets damaged or dysfunctional, it starts the path to dysregulated cell growth, which is the definition of cancer. So the definition of cancer is cell division out of control, disorganized cell growth. And that starts with damage to the mitochondria in the cell, leading then to downstream genetic mutations. So the myth is that cancer is caused by mutations. The truth is that the mutations are the result of the damage to the mitochondria. So most of what we do in the clinics to manage the disease, most of the research that's being done throughout the world is probably a waste of time. And I say that because we're not making any major progress in managing cancer, and that's because the theory of the disease is incorrect. And once people realize it's a metabolic mitochondrial problem, then you're going to see real achievements in reducing the deaths from cancer. So the greatest myth, cancer is a genetic disease, is a myth. Cancer is a mitochondrial metabolic disease, and that's the truth.
What I appreciate about hearing that is so many of us feel like my father had this, my mother had that, my siblings, my grandparents, so then I'm probably doomed and I'm afraid I'm going to get what they got. So I love hearing that cancer in particular is not genetic, because that helps a lot of us with our anxiety and fear. And also what you're saying helps us feel like perhaps we have a little control of what's going on, instead of just feeling like, oh my gosh, I got this diagnosis and now I got to trust in the doctors and I'm losing control of my body.
Yeah. Well, I think you have to recognize there are genetic risk factors. Like you mentioned, the BRCA1 and P53, these are risk factors. They only put you at risk if those genes damage the function of the mitochondria. And no known genetic inherited risk factor is 100% penetrant. Even those who have BRCA1, the mutation that affects or breast cancer, about 50 to 60% of women that would have that mutation are at risk for developing cancer of the breast, but 40% are not. So you don't, and you can modify that by things you can do to reduce the risk significantly. So there are genetic factors that are risk factors, but they're not the cause of the disease. Because if they were the cause, everyone that would inherit that mutation should get the disease, and that's clearly not the case. So yes, you are in charge of what you can do to reduce your risk. Even if you were diagnosed and said, oh, I have, like you mentioned Angelina Jolie. Well, she went out and had breasts and ovaries removed. But if you could also use diet and lifestyle modification to reduce the risk as well. So, because it's not a fait accompli that if you have that mutation, you're going to get the disease. It can be modified. So the only origin of cancer is damage to the mitochondria. If the mitochondrial damage can be avoided, cancer will be avoided.
Oh, you just had me thinking. So do you think it's better to cut and chop, like take off our breasts and our ovaries or take out our prostate? Or should we maybe cut and chop food? Is it food that
Well,
can
I don't. I certainly, if the mutations, and besides, just because it might involve, like the highest prevalence for a genetic risk factor is the Li-Fraumeni P53 mutation, where about 80% of the people with that mutation will develop some form of cancer. 80, but not all. So it's not 100%. There's no mutation that we know of that causes cancer 100% of the time, which means, and P53 is a mutation that affects mitochondrial function. So clearly that gene damages the organelle that's responsible for the origin of cancer. Now, you can remove organs, but with P53, but you could get cancer in almost any organ. So what are you going to do? I mean, you can't go out and remove all your organs to prevent you from, right? Think about it. It doesn't make any sense. So, but you can try to reduce the risk, because if you can keep your mitochondria healthy, the probability of getting cancer is very rare, almost remote. And how do we know that? Well, we know that because every known cancer has damage to the mitochondria, and they ferment. They get their energy through a mechanism that doesn't involve oxygen. So they get energy without oxygen, and that's called fermentation. And our primitive ancestors, are what they call aboriginals, rarely, if ever, had cancer. The great humanitarian Albert Schweitzer would look at the African populations in the jungles. They never had cancer. He never could find anyone with cancer. The investigation of the Eskimos and Native Americans before Western civilization came into the lives of these people, cancer was unheard of. Our closest genetic relative, the chimpanzee, is 98% similar to us in genetic background. They rarely, if ever, there's never been a documented case of breast cancer in a chimpanzee. So what's going on with this? Why are native ancestral humans and chimps and things, they don't get cancer? So what is making all of us so susceptible to cancer, right? And it's diet and lifestyle. The Western diet and lifestyle is putting us at risk, not only for cancer, type 2 diabetes, obesity, cardiovascular disease, dementia, all of the major chronic diseases, including cancer, are all the result of diet and lifestyle issues. We're constantly bombarded with high fructose foods, poorly nutritious foods. We don't exercise. We're stressed out. We're doing all those kinds of things put us at risk for damaging the mitochondria in a population of cells, putting us at risk for cancer. Okay. So the prevention of cancer is keep your mitochondria healthy. If you keep the mitochondria, how do you do that? Well, you do restricted food intake periodically, eat foods that are very low in carbohydrates. Don't forget, our ancestors never had access to Hershey bars, or they never had a supermarket full of highly processed foods. They'd have to go out and kill what they ate or grow some vegetable that they could eat. They weren't driving up to McDonald's and having somebody hand them a big Happy Meal through the window. They don't even get out of the car. They don't even use the exercise to get out of the car to get the food. I mean, you try to compare that with trying to run down a big elephant and kill it and butcher it. I mean, there's a lot of energy that goes into that, and there's no sweet involved with that, right? So think about it. Those people never had cancer. They say, whoa, they didn't live long enough. Believe me, they did. There were some people that lived quite a long time, and they never. So we already have well documented from a variety of different ways. Oh, they say these people never, our ancestors didn't, when the Eskimos, they didn't go to doctors. That's not true. They love to go to doctors. This is reported by Robert Lufkin and some others. or not Robert, but Sam Apple. And so we have plenty of evidence that cancer is a disease of civilization. We ourselves, our diets and lifestyles are putting us at risk. And so the way you can get away from this is try to adopt a diet lifestyle issue that reduces risk factors.
If you want to learn how to implement the ketogenic diet and the Press Pulse protocol into your cancer management, just visit school.com/keto for cancer, the new community by our research analyst Johnny Rockermeyer. Within this new community platform, you can connect with other patients and learn from their experiences. You can also just search through the posts other members have already made. You will have access to our classroom section as well, which provides practical advice and tools for the best results. These sections cover all parts of the Press Pulse protocol that you should implement. Starting with the general scientific concepts by Dr. Thomas Seyfried, we will show you how to start the ketogenic diet, including which foods to choose and which to avoid. Additionally, we prepared a list of doctors specialized in metabolic therapy, as well as details about glutamine inhibition and hyperbaric oxygen protocols. So, take a look around at school.com/keto for cancer.
Right? Smoking. Smoking was a terrible risk factor for cancer. Now our society has come to realize that we stopped smoking for the large part for many people, and cancer rates went down tremendously. Okay, but right now, every day we have over 1,600 people a day dying from cancer in the United States, documented by the American Cancer Society. Every year they come out with their numbers. You know, how many new cases we have and how many people are dying from cancer. And you see the numbers are quite sobering. What is going on with 1,000, over almost now 1,700 people a day are dying from cancer? And it doesn't go down, it goes up. And people say, well, it's going, it is. It's increasing at the same rate as the population is increasing. But there's no drop. We're not dropping death rates from cancer. All those drugs you hear about advertised on television, the Keytruda, the Opdivo, chance to live longer, do this and do that. It's all bullshit. It's all based on the gene theory of cancer. If cancer is not a gene, if it's not a genetic disease, all that stuff is down. It's never going to reduce significantly the death rate because the theory based on the treatments is incorrect. It's a metabolic disease, and we can take charge of that. We actually can. We have the capability of modifying our risk for cancer, type 2 diabetes, heart disease, all of these things. I mean, we have an obesity epidemic, right? Everybody knows this. They don't want to talk about it. Obesity is now replacing smoking as the #1 risk factor for cancer. I mean, we have control of that. I mean, it's not easy, but you can control it. All the risk factors, most of the risk factors for cancer are now controllable when you understand that it's a metabolic disease and not a genetic disease. Because people who think it's a genetic disease say, oh, it's my bad luck. That's incorrect. It's incorrect. The mutations are all downstream effects. They're not the cause. So we're focusing almost the entire cancer industry is focusing on downstream epiphenomena, not the real problem. So in a nutshell, that's what it is. We published a lot of papers on this. The problem is it's a message that few people want to hear. Certainly the pharmaceutical companies don't want to hear it. Certainly the academic cancer industry does not want to hear it. And also the people, the population of people in our society are not really excited to hear about it. They'll roll the dice and say, oh no, I like to eat the way I am and I like to do what I like to do. I'm very comfortable and I'll roll the dice and maybe I won't get cancer. So, but they can take charge of it once you know how to manage it. So, and where its origin, if you know how it starts, you know how to manage it. So it's not an insurmountable problem. It's just that, we have people in the society that may not know this.
So many questions. So my first one is, you just mentioned number of people dying of cancer. How many are actually dying of cancer or the treatment? And there's a reason I'm asking it. It's regarding my father.
Yeah, no, that's an extremely important question. And it's a very interesting kind of question because I think a significant number of people treated are dying from the treatments. And let me give you a couple of examples. Well, first of all, you know that if you're exposed to toxic poisons and radiation, that's not healthy. That for some people who are on the cusp of ill health, that can push them over. Also, you also see many times they'll say he died from the complications of cancer, which is often he died from the treatment. Now, in the Wall Street Journal, and I share this with my students, I tell my students in the cancer class and in my general biology, you get a lot of information on cancer from the Wall Street Journal. So for a variety of reasons, most of it's a new drug that's going to come out and see how much profit you can make on this new drug, which is based on the gene theory, which is obviously not going to help many people in the first place. But Paul Allen of Microsoft fame died at Fred Hutch, I believe it was in Seattle. And the Wall Street Journal said the doctors were very optimistic about his prognosis. And within a couple of weeks, he was dead. And he died from the complications of whatever they treated him with. And he's one of the wealthiest guys in the world. And then Blake Nordstrom of the department store chain, Nordstrom's department store, he had some sort of a lymphoma, according to the Wall Street Journal. The doctors were very optimistic. And within 2 weeks of his treatment, he was dead. You know, you don't die from cancer and lymphomas in 2 weeks, right? So what happens is the people that are rich and have a lot of money go off to their medical schools to get the latest treatments, okay? The poor people can't afford all that stuff. So they have a better chance of survival than the rich. They go off and they get all these special immunotherapies and all this kind of nonsense. And the next thing you know, they do really well at the beginning. As a matter of fact, it looks like, whoa, miraculous. It's miraculous. As a matter of fact, it was shown, big paper published, that many of these drugs, they make the tumor look like it goes away, but you only live 2 extra months, 2.4 extra months. Can you believe this? I mean, we are so given so much misinformation by allowing drug companies to peddle their drugs on TV every night, giving the false impression to the population that things are really hunky-dory. And if you have a cancer, we know how to treat your special cancer. We have the tools. Are you kidding me? We got 1,600 people a day dying. And yes, we have a lot of survivors. People say, oh, it must be worried about a lot of survivors, right? But a lot of those cancer survivors pay a terrible price for their survival. I mean, they're surgically mutilated, they're burned, they're poisoned. I mean, a lot of times they have all kinds of other maladies associated with the treatments that they were given. Oh yeah, I survived my cancer. You know, it was really tough battle, all this stuff. But now you have digestive issues, hormonal issues, neuropsychiatric problems. You got all kinds of problems for surviving your cancer. That's nuts. You shouldn't have all that. That's nuts. What are they doing? So, and the answer is, if cancer is a mitochondrial metabolic disease, we can drop the death rate by 50% in 10 years, and we can bring people's health back. Not only will you, yes, of course, this is clear, but it's impossible. Of course it's impossible if the theory that you're treating the patients with is incorrect. Yes, it is impossible. But if the theory changes to a metabolic disease, yeah, very possible. The problem is, no one has yet figured out a business model to make money on it. And until that happens, we must then be sacrificed by the system because we can't make enough money. Revenue generation is the number one aspect of cancer. You got to generate revenue. Now, if I have a drug that can generate revenue and manage your cancer without toxicity, everybody will love it. But we don't have that. But we can manage your cancer without toxicity. The problem is we can't generate revenue on it. So these are the problems. And until the society steps back and says, yeah, we got to do something, it's going to be status quo. There's not going to be anything that's going to happen. So they're all going to run off to their Dana-Farbers, MD Andersons, Sloan Ketterings, Fred Hutch, wherever they go, MD Andersons, right? They run in there, they get all the different kinds of treatments, and they do good for a while, and then you hear, well, there's nothing more we can do. Give me a break. You know, I mean, it's just tragic. It is the greatest tragedy in the history of medicine, this cancer thing. And, but, until we have to keep publishing the papers, we have to keep documenting all the case reports that we're showing. Oh, they say we don't have enough. I won't believe it unless I see a big case report. And then after you do a case report, they still won't believe it. So it has nothing to do. The outcome is, why don't you look at all the case reports and how well they're doing and say, well, that's a fluke. He's a fluke. That's a fluke. This is a fluke. Well, one of these days, the patients are going to say, I want to be one of those flukes. So the system has to change. If the system doesn't change, then it's going to be business as usual, suffering, dying, and all this other stuff that's associated with the disease. And it's a tragedy. People fear cancer. As soon as they get the word, I'm diagnosed with cancer, they impending doom and death. It doesn't have to be that way. It doesn't have to be that way, yet it is, because they fear the treatment as much as they do the disease. And why? Oh, I'm going to lose my breasts. I'm going to lose my prostate gland. I'm going to take my kidney out, take my lung out. They're going to poison and irradiate me. Who the hell wants that? Oh, I got to do that if I want to survive, right? But you don't have, we can survive, if you survive without having to do all that. Oh, I don't believe. Oh, okay, you don't believe. I published all these papers. What part of it you don't believe? Oh, I never knew that. Oh, people say, I never saw that paper. Well, you don't read the damn literature. If you read the literature, you'd be saying, oh, and you can't believe how many people say sugar has nothing to do with cancer. Now, sugar doesn't cause cancer. It's not a carcinogen. But if you have cancer and your blood sugar is high, you die faster. The tumor grows faster. It's clear. Hundreds of papers published. And then you go to an oncologist and sugar has nothing to do with cancer. What, are you kidding me? These guys don't read the scientific literature. So I don't know what to say. I mean, what can you say? I'm on here talking on your show. I'm telling you and whoever's listening. Right? This is the way it is. They don't believe me. Then read my papers and see what you think. Right? If you say, I don't believe it. Well, hey, listen, there's a lot of people who actually believe stuff that is incomprehensible, that anybody could believe some of these things. But what are you going to say? But anyway, you can always look at my papers and read the information and see it if you don't believe what I'm saying.
We're going to go over your papers in a moment. And I'm also going to ask you in a moment about Steve Jobs and pancreatic cancers, because I'd really like to go over the most dangerous cancers, but I'm tell a story real quick. The reason I asked you, because I have experience in this, how many are dying of cancer or the treatment? So when my dad got COVID, our whole family, except for me and one son, I guess because we're O blood, I don't know, got the COVID in June of 2020. Now, my dad at the time, he's 80 now, totally fine for who he is. He was 78, obese, sedentary, prostate cancer, AFib, high blood pressure. I used to say high cholesterol, but now we know it's a myth, and I'll talk to you about that in a moment. So my dad was at the hospital because his oxygen was 88. So God forbid he was dying of COVID. And what did I do? I said, Mom, I don't know how this hospital treats it. I know Dr. Thomas Yadigar at Tarzana Hospital in California, Cedar Providence. He knows what he's doing. He's saving tons of lives. We pull him out. My mom signs an AMA paper against medical advice. They warned us it might not be covered by insurance. We said, we don't care. Take him to Tarzana. He was there 5 days. The doctor said, basically, I'm not going to say who, a doctor who I spoke with said, your dad was dying. I know the way this disease goes. They're treating him for pneumonia at that hospital. Here we treat for cytokine storm. And I think a lot of what you're talking about, probably we can talk about cytokine storm. So that's why I asked you. A lot of people ran and did certain things to their body because they were so fearful. And I feel blessed. I didn't have to run and do anything. I said, you know what? I think if we go to the right doctor and we have the right hospital, we probably have a chance with COVID. But what I noticed, and what I noticed is not only was it obese people, and I talked to 2 lung specialists dealing with COVID, it was alcoholics. It was anyone inflamed. It was people currently going through cancer treatment. It was people who, I noticed bodybuilders, Professor Dr. Seyfried, it was bodybuilders, it was long distance runners, anyone who was overly doing it, like too fat, exercising too much, they probably had cytokine storm. So we'll talk about cytokine storm. I'll get back to my other questions. Do you talk about cytokine storm at all?
Well, cytokine storm is, it's in the case of cancer, it would be tumor lysis syndrome. And some people die when they get an immunotherapy. It can sometimes kill so many cancer cells together at the same time. They release a massive amount of, it's a cytokine storm basically, and they die quickly from that. So, our approach is to grade the tumor slowly over time using the press pulse metabolic therapy. So we completely avoid any cytokine storm or tumor lysis syndrome. But you're correct in defining that many of the people that did suffer and die from COVID, most of them had some sort of comorbidity with their condition, whether they were older or even younger people that are immunocompromised or obese, or there was a whole slug of things that would put you at risk. And again, where did all those people develop the risk for being killed by COVID? The diet and lifestyle issue. It comes right back to the fact that if you're young and healthy and in not overly great shape, like you mentioned with some of these people, the probability of dying from COVID was much less than people that had all these comorbidities. And most of those comorbidities have come from diet and lifestyle issues. And many of the comorbidities also put people at risk for cardiovascular disease, cancer, and high blood pressure, hypertension, all these other kinds of things as well. So everything comes back to metabolic homeostasis within the body. And if you have metabolic homeostasis, you're more likely to survive a variety of different assaults on the body.
So again, we're going to get back to the dangerous cancers and Steve Jobs in a moment, because I don't want to leave that question hanging, but I think a question people are going to say right now, but Professor Dr. Seyfried, what about the 2-year-old child? What about the teen? And I'll ask a question. I'll give from my friend. She said, I lost a 16-year-old daughter 7 years ago to small round cell desmoplastic sarcoma, a very rare cancer. She was diagnosed at 14. What could have been wrong with her metabolically to have caused this? What could we have done differently?
Yeah, well, how that initial disruption of the mitochondria happens can sometimes be easily determined and sometimes less easily determined. So for a 14-year-old girl to have a mitochondrial abnormality in a population of cells that ultimately grew out of control is not clear in that case. In other words, what could that young lady have done to prevent herself from getting that cancer? Again, at 14 years old, and most of the young people, they don't really think about themselves getting cancer, nor do the parents of those kids. The issue is what could have been done to help her survive in a more a less toxic way. Now, metabolic therapy that I speak about, we don't call that a cure for cancer. We call it a logical management of the disease. If you happen to survive very long periods of time, like into your 80s and 90s, and happen to die from a stroke, then you can possibly say that metabolic therapy that was treating my cancer when I was 14 or 20 or whatever was probably, because obviously the guy died from something else in his 90s. So you don't know. People say, oh, I don't think of a cure for cancer. What you think of is a logical management of cancer. So that's what we think of when we say, oh, how do you, we don't cure, we manage. Can you manage the disease without creating toxicity? So the 14-year-old girl, I can't tell you how she might have gotten the origin of that, but we would certainly have a logical strategy for managing it. Whether she could have been cured or not, she probably would not have died in such a rapid way, or in a difficult way. So we're working on all that. And once we already have the blueprint plan. I'm sure we can keep most of these cancer patients alive far longer with a higher quality of life and overall survival. Whether they're cured or not, I don't know. We've only been doing this for a while. I mean, we've got 8, 9, 10-year survivors, but are they cured? Who knows? I mean, if they die from old age from something else, then yeah, they would. I won't be around to see those people. They might live longer than me. So what am I going to say?
You were talking about rich people getting the best treatment, yet sometimes it kills them faster. So I was thinking about Steve Jobs.
You encapsulated that pretty clearly, didn't you?
I'm sorry, we're laughing.
That's a terrible thing to say, right?
Terrible. But that's what scares us the most. This is the boogeyman. That's why I have you on the show, to help people from the anxiety and stress, thinking the boogeyman's going to come to get me. If someone like a Steve Jobs gets a pancreatic cancer and he can't live, then surely I'm not going to live. So can you talk to us either about pancreatic cancers or just the most dangerous cancers in general that seem to have no cure?
Yeah, well, when you cure, well, it's surgery. If you can catch a cancer early, like the size of a wart, and surgically debulk it, you're probably cured. So it's when they metastasize and start to spread to other tissues and around the environment, which then becomes a little bit a much greater challenge. But Steve Jobs, he had pancreatic cancer. He lived quite a long. I don't know what kind of pancreatic cancer he might have had, but I know he said he was doing some dietary stuff. But for those who have pancreatic cancer, glioblastoma in the brain, non-small cell lung cancer, all these kinds of cancers. It metastasizes quickly and spreads around the body. But what we know is that they are all similar. I did a big study on this. I compared the underlying problem in all of the major cancers that we know of, which includes about 99% of all major cancers: pancreatic, glioblastoma, lung, all these different cancers, bladder, colon, breast. They all generate energy by using without oxygen, which is called fermentation. And then once you understand that energy can be generated by breathing air, or by these cells get energy without breathing. So they live in hypoxic, non-oxygen environments. But in order to live in that environment, they have to, you call fermentation. It's ancient pathway of energy before oxygen came into the atmosphere 2.5 billion years ago. So the cancer cell is doing nothing more than falling back on an ancient pathway of energy metabolism, depending on two fuels: glucose, the sugar, and the amino acid glutamine. So if you pull the plug on those two fuels, you can manage the majority of cancers, as long as you transition the body over to ketone bodies, which are water-soluble fat breakdown products. So the solution to the cancer problem is not that complicated. You just take these people, you deprive the tumors of their very necessary fuels, and while transitioning the body over to fuels that cannot be fermented. So it's actually embarrassingly uncomplicated. But when you look at cancer from the perspective of a genetic disease, it's hopelessly complicated. So once you understand the metabolism of what's driving the growth of the tumor, whether it's a pancreatic tumor, a glioblastoma, a bladder cancer, any of them, they all ferment. So the plan to eliminate them or manage them becomes much more clear and far less toxic. So that's the strategy. Our case reports that we're writing over and over again on individuals demonstrate that people that should be dead are alive. There's a movie that will be coming out called The Cancer Revolution. I think they're going to the one of those documentary film fests, I think, in somewhere in Utah, where they have those film documentaries. Anyway, in there they've interviewed many long-term survivors of the most deadly cancers that have used metabolic therapy to manage their disease. And everybody writes them off as flukes or anecdotal and things like this. But it's only a matter of time before more and more and more of these kinds of cases start appearing everywhere. And the people who survive start telling everybody, how wonderful I'm doing and all this. And then people will say, I want to be one of those flukes. I want to be one of those anecdotes. And then the oncologists at the hospital say, we don't do that. We don't treat you like that. In fact, they get angry and they want you to do their standard of care. So this system is has to change. How many people want to continue with what we're doing? How many people are satisfied with the progress that we have made in managing cancer when we have over 1,600 people a day dying from the disease? How many people are happy with the fact that they have to subject themselves to surgical mutilation, radiation, and poisons? I don't think there's a lot of people that feel good about that. Nobody gets into a happy state when they get diagnosed with cancer. So I'm not saying that with metabolic therapy, that you're going to be, oh, wow, I have cancer now. Now maybe I can get rid of my high blood pressure, diabetes, along with the cancer. So, and that's what we're seeing. A number of people that come in to do metabolic therapy for cancer have diabetes and high blood pressure and all these other things, and they all go away with the tumor. So Guy Tannenbaum, you should interview this gentleman. Advanced prostate cancer. He had 9 months to live, they said. He's out now 3 years, and he's doing remarkably well. He lost 110 pounds. He got rid of his high blood pressure, his type 2 diabetes, hypertension, got rid of it all, and his prostate cancer. And people say, oh, I want to do what Guy does. Well, Guy did water-only fasting for like 10 or 12 days at a time with intermittent keto. And so, well, okay, I don't want to do what Guy's doing. Okay, then take the chemo and radiation, get your prostate pulled out. I mean, these are the choices, right? So But more and more people are going to say, and he's on the web telling everybody how healthy he is. He feels great. He's wonderful. Never felt better in his life. It's like, so it's a metabolic therapy which can manage not only cancer, but a lot of the conditions that put the body at risk for developing a neoplasia or a tumor in the first place. So, but people say, oh, if that's so true, how come everybody doesn't want to do this? How come everybody doesn't know about it? And the answer is, you ask how many people would really bite the bullet in compliance and say, oh, I got to eat a diet now that has 0 carbohydrates. And I test it with my students, myself and stuff. I mean, it's great for the first week or two. And after a while you go, wow, man, this is really tough. Or water only fasting. You have to change your mindset. The mind-body relationship has to begin to change. The motivation is you want to stay alive. The goal is, how long can I stay alive with a diagnosis of cancer? How can I manage my own disease with the help of knowledgeable professionals who can guide me through the gauntlet of what I need to do to maintain control of the growth of these cells? And I want to degrade them slowly over time. And that's metabolic therapy. So ketogenic metabolic therapy will be eventually the solution to the cancer problem, but it's going to take a while for the system to recognize that and change. It's going to happen unless people are very happy with the way the status quo. And if they are, then take the radiation and chemo and immunotherapies and all that other stuff. I would never do that, but maybe somebody else would do that. I don't know.
My friend Dovey actually sent me some videos from Guy Tenenbaum. And what I saw is at some point in his cancer, he did a 45-day water fast. So he had to add vitamins or some certain food. I think he did 35 days of something, no?
Yeah. No, it wasn't 45 days. I think he when he came into my office here, he was on an 18-day water only fast.
Oh. Now,
you don't go out and do that. That's like saying, oh, I want to run a marathon. Let me run. Did you practice at all? No. I weigh 300 pounds. I want to do a 26-mile run. How do you think that's going to go? Not well, right? So a Guy Tannenbaum did small fasts at the beginning. He built his body up into a tolerance routine, and he was eating. He then would start to eat the kinds of foods that would be extremely low glycemic, highly nutritious kinds of foods, and he balanced his body. So, but he is a survivor, long-term survivor who got rid of a lot of other conditions that he had, but he's not alone. I mean, we have many people that are doing this. You just have to know, we developed the glucose ketone index calculator to allow cancer patients to know whether they're in this therapeutic zone. And then once they get into that therapeutic zone, then we give them certain low dose drugs that work together with this new metabolic state to precision kill tumor cells. Our metabolic therapy is the real precision medicine. What it does is it enhances the health and vitality of your normal cells while killing tumor cells without toxicity. That's precision medicine, not this immunotherapy crap and all these other crazy things you hear. They're all based on a flawed theory. When the theory is wrong, those things are not going to be, yes, they will help some people, but they're not going to help the majority of people that have all these different kinds of cancers. Metabolic therapy will be able to manage cancer in the majority of people, okay? But they need to know what to do and how to do it. They need to have professionals that will guide them, consult them, and show them what they should do and what they should not do. It should be a feed-forward feedback between the patient and the caregiver. The problem is we have very few physicians that understand anything about what I just said. They're clueless as to recognize the biology of the disease they're treating. They don't know cancer is a mitochondrial metabolic disease. How could you treat somebody for a disease when you have no clue as to the biology of the disease you're treating? So there has to be a real educational, there has to be trained people that understand cancer is a metabolic disease. How are we going to help all these people use, and you have to get people that buy onto this. You have to have people that are motivated to want to do this. Listen, there are some people, no matter what you say, they can't give up food for 5 hours, right? Okay, we have radiation and chemo for you. Okay, we're not going to take that away for those people that lack willpower and self-discipline. We definitely have the radiation chemo immunotherapies. We'll be more than happy to treat you that way. But for those people that want to take charge of their own soul and existence, we have another alternative approach that you might want to consider once you become educated enough and work with an individual that understands the concepts. Makes sense, right? Right? I mean, this doesn't make sense to people. I don't know. I mean, we consider it the new way to view cancer. So we don't ever want to stop somebody from taking radiation or chemo. I mean, if that's what they desire, we think that should always be available for that. So we don't want to say, oh, people should never be irradiated or treated with toxic poisons to kill their tumor. You know, if that's part of the standard of care, you know, some people say, you know, I think I need radiation and I think I need a lot of chemo. Okay, well, it'll be there for you. But for those people who don't want it, why don't we tell? Right now, the system does not allow people to recognize that there is another way to manage cancer that is non-toxic, but it requires a lot of personal discipline. And you know, if the person, well, I don't have any personal discipline, great, then you do the standard of care. So, but the alternative should be there, and it should be, people should know about it. At least they have the option. I'm not saying people should do metabolic therapy any more than I should say they should do the standard of care. Whatever they think they should, in their particular lifestyle and the way they view it, they should have the choice, or at least they should know about it and compare and contrast what should be done for managing their particular condition. So right now they get no choice. It's either this way or the highway, standard of care or the highway. You know, you don't really have any other options. And when you ask most oncologists, is there another way? No, this is the way it is. So, and that's wrong. There should be options. They should be given options too.
What I appreciate most about all of the lectures and everything I've read that you've written and all your thoughts is that once we get a scary diagnosis, especially cancer, we feel like friends throw things at us, doctors throw things at us, neighbors, everyone's giving us their opinion, and we don't know where to go. Who do I trust? What do I do? So what's interesting, I'm going to relate this to what just happened to my dad. So my dad has COVID-19 right now for the second time. He's 80 now. And he went to the hospital. They said, you're COVID positive. And they gave him a pill by Merck called Lagevrio, something like that. So I look, it says released by emergency use, experimental, and it says not FDA approved. So I said, Dad, hey, let's read the product insert. What are the long-term side effects? What are the short-term side effects? We don't know. So it's a very similar thing with cancer. We get a lot thrown at us. Do we even look at the product insert to know what we're putting in our body, the injection, the radiation, the pill, the treatment? So I appreciate that. It sounds like you're teaching us we have a little more control than we think.
Yeah, we do. But you raised an extremely important point, because there are a lot of medications that can target the energy metabolism of the cancer cells with minimal side effects, like embendazole and fenbendazole, these parasite medications, which are really cheap, and they're very effective and very non-toxic. But again, you have to know how to use this. And there's many drugs that are not FDA approved that could be extremely powerful when used under nutritional ketosis. We've tested them, the drug 6-deoxynorleucine, which is DON. I've spoken about this. We used it here in the clinic or in our preclinical models, and we got really, really good results. It's a glutamine targeting drug. And it really works well, but again, it was used on children with cancer, people with cancer in the past, and they said, oh, it was too toxic and didn't work. Well, you gave it at too high of a concentration, you didn't know how to use it, and you weren't targeting the glucose at the same time you were targeting the glutamine. So you're not going to get the complete efficacious control if you don't know how to use the drug that you're working with. Again, but now it's not for human use. All I can say is if I were diagnosed with cancer, I would get myself into nutritional ketosis as fast as possible. I would buy Don. I would get it from a company. I know where to get it, and people can get it. Their problem is they won't sell it to you, but I can get it. Well, how can I get it? Well, I can get it in different ways. I've tested drugs from China. I've tested them to make sure the ones, because some of that stuff may not be good. I test the ones that are good. So yeah, and I would have one of my friends deliver it to me, IV, right? And I would take all the things that I've been working, and I see all my clinical stuff. The problem is people can't, Like your viewers, they wouldn't be able to do that. But I know people who have enough, some people have a lot of money, so I want to do that. I'll say, okay, you can buy the drug, and then you just got to find a clinician that will sign off and say, okay, what are you worried about? You think Dawn is going to be as toxic as some of those immunotherapies that are killing people? I mean, you got to put things into perspective. People say, oh, the ketogenic diet has a lot of adverse effects. Like what? Like compared to radiation? Are you kidding me? I got to stop eating carbs. It's going to be worse than me taking a toxic poison. I mean, this is nuts, right? So it's the mindset of the people. So, but yeah, no, there's a plan. We wrote the press pulse concept. It was a strategy. You have that paper there with my physician colleagues. And yeah, this stuff will work, man. You just got to educate people and the physicians. You have to educate the physicians and the patients together. And then you start to see big changes. You can get my papers and read them. So Press Pulse was a strategy by which we use a diet to stress the tumor cells and then very low doses of drugs pulsed to kill off the survivors. So it's a logical strategy for gradually degrading the tumor population while enhancing the health and vitality of the normal body. So it's not to be viewed as a bull in a china shop, like let's irradiate this poor guy or this organ until it's like incinerated. Why are you doing that? Well, I want to get rid of the cancer cells. But why don't you just slowly degrade them by starving them to death of the energy that they need using a press pulse metabolic therapy? Well, I didn't know anything about that. Well, why don't you read the paper and then discuss it with your oncologist? So the patient comes in, he says, oh, wow, I discussed it with my oncologist. And my oncologist said, we don't do that. So now what? So the poor patient is always left in this limbo that doesn't know what he or she should do. Yet the strategy is there, but the very professional that's supposed to help him go through this doesn't understand the concept. So you have all of these issues that are standing in the way of having a very logical, non-toxic way to manage almost everyone's cancer, most of the people. We should be able to manage our cancers in a very logical strategy using press pulse metabolic therapy, which we published. So it was a skeleton outline. We're working on a big paper right now, which is really a protocol for treating the patients with metabolic therapy. So I'll have a lot of my physician colleagues with me, working with me on that paper, so that we can, again, put it out into open access. Have the cancer patient wave this paper in front of their oncologist and say, please do this for me. It's clearly outlined what you need to do, dosage, timing, and scheduling. Please do this for me. And what they do is chase you out of the office. They're trained to do only the standard of care, and they're not trained. And then you get these other guys who say, well, we're going to give you a whole bunch of supplements and all this crazy stuff like snake oils and all this nutty stuff. But we're not going to use toxic poisons, but we're going to give you a whole bunch of supplements. Like what? How is that going to target glucose and glutamine? How is that going to put you in a state of therapy? So you got to, and you are 100%, Amalia, where the poor cancer patient goes. He gets all this misinformation, right? He goes to the top medical school, gets misinformation. He goes to some alternative guy and gets misinformation. So the poor guy is, like you said, he said, she said, oh, do this, do that, don't do this, don't eat that, don't eat that. And it's like so confusing for the cancer patient. We know exactly pretty much what you need to do. We publish the papers, but we can't find, it won't be adapted by the medical establishment. So again, we have the same, to some extent, the same kind of problem. We can't get the word out to the people or the methods for doing that. Anyway, it's a struggle, but eventually, in some point in the future, it will happen. So it just takes time. You just have to hope that it happens sooner than later.
Do you see your book? I pulled it up. Can you not see the screen? So I remember last time you had to press screen
in oncology, but I think that's our most recent paper, but it's not the one that the press pulse metabolic therapy. Don't worry. I mean, the people can get all of our stuff on open access. So there's interesting one paper I published recently though on prostate cancer. In Nature Urology. So Nature is like one of the top scientific journals. The problem with that paper is that you have to have a subscription to Nature to get the paper. So most people are never going to see it. Published in a very prestigious journal, but nobody can read it. So what good is it? It's not as important as the open access papers. So you can see all that. Yeah, I see the Frontiers thing here, but that's our new paper in brain cancer.
Okay, what about, do you see the one with managing breast cancer, ketogenic metabolic therapy?
I don't see it on my screen, but
Strange. Okay, can you tell us about that? It's in Frontiers articles. It says consideration of ketogenic metabolic therapy as a complementary or alternative approach to managing breast cancer.
yeah, well, I mean, you can say I could have substituted that with lung cancer, pancreatic cancer, colon cancer, bladder cancer, lung cancer, because they'll all respond in a similar way. Someone reached out to me in the breast cancer field, and I have a lot of physician friends who are working on breast cancer. And some of the results on some of these women are unbelievable. People with advanced metastatic breast cancer that goes to the lungs and the brain. When you have your metastatic cells leaving the primary site of the tumor and then spreading to other organs like the liver and the lung and the brain, that's pretty much lights out. But my colleagues use metabolic therapy, and we're able to keep these people alive so much longer in a much higher. And then what we need to do is, and a lot of them go through standard of care and so beat up, it's just unbelievable. They're emaciated and all this. And then we still sometimes can rescue. We can't rescue some people. Some people are so badly damaged from the toxic treatments that their normal cells can no longer rally. And because don't forget, metabolic therapy relies on our normal cells as direct competitors with the tumor cells. So if you keep your normal cells healthy and strong, they'll outcompete the tumor cells, which are much weaker because of all the problems they have genetically and metabolically. So it's a struggle. The normal cells struggle against the tumor cells, but you got to keep the normal cells healthy, and you got to keep the pressure on the tumor cells and gradually degrade them. They gradually start dying off. As your body starts getting healthier, the tumor cells gradually, because you're using diet drug cocktails. The tumor cells cannot survive under those diet drug cocktails. You're taking away the two fuels needed for their growth and survival, the glucose and the glutamine. And once you do that while keeping the rest of the body healthy, these damn tumor cells up and die on you. Now people say, whoa, wow, how can you do that? I published these papers. Why don't you look at the data and tell me what you think?
I love it. I'm going to pull up another one of your papers. How about metabolic management of microenvironment acidity and glioblastoma?
Well, that's our newest paper. That just goes to show that, why is it so hard to manage glioblastoma? Now, don't forget, glioblastoma is pretty much a death sentence for most people that have it, right? John McCain passed away of glioblastoma. President Biden's son, Beau Biden, died of glioblastoma, right? Edward Kennedy, Massachusetts Senator Edward Kennedy. I mean, these are high profile folks. And if there were a solution to the problem, don't you think those guys would have been ones to get it? But they're all dead from it. But they go into high dose radiation and chemo and all this crazy stuff, and it creates an acidic microenvironment that actually allows the tumor cells to survive even better. So as soon as they survive that first radiation blast, it's like the worst thing you can do to a brain cancer patient is irradiate them. And yet they do it over and over again. And I told them, you're contributing to the demise of the patient by doing that. And you think that would have echoed with somebody's ear? No, got to keep doing that. And I pointed, I never heard of that. I didn't know radiation could make the tumor grow faster, because you don't read the damn literature. We published all these papers showing that the radiation frees up the two fuels that the tumor cell absolutely needs to grow, and you guys making it worse. And they say, well, we didn't hear about that. We didn't have that in medical school. Well, I said, whose problem is that? That's your problem, not mine. I published the papers to show you how this is all working, and all your patients are dying, right? Why don't you look at the survival? 15 months. If you can make 15 months with a glioblastoma, you're doing really well, And yet they do it over and over again, expecting a different result. What did Einstein call that? He called it insanity, doing the same thing over and over again, expecting a different result. When is the field? We have not made a single advance in glioblastoma in 100 years. Think about this. We have the Webb telescope orbiting 1 million miles from Earth, looking at the origin of the solar system. And we still have no advance in the glioblastoma field. Can you believe this? Why? because the theory under which they're treating the patients is incorrect. You're never going to get any advance if you keep doing the same stupid thing over and over again.
Are you passionate about the groundbreaking and heroic research of Dr. Thomas Seyfried on metabolic therapy and cancer? So are we. That's why we've created something special for you, in collaboration with Johnny Rockermeyer, a German book publisher and translator. Introducing our collection of meticulously crafted books that distill the essence of Dr. Seyfried's work. Dive into the science and discoveries. These summary books are your gateway to understanding the intricate world of metabolic ketogenic therapy in a clear, concise, and engaging way. Whether you're new to the subject or a seasoned enthusiast, our books offer insights that can change your life. Ready to explore this transformative knowledge? Visit our website at www.cancerasametabolicdisease.com to get your copy. You can buy the ebook there directly and the paper book via the provided links. Here's the best part. A portion of every purchase goes directly to support Dr. Thomas Seyfried's groundbreaking research. That's why the direct ebook purchase is the best option to donate as much as possible. You can see all of the donations Mr. Rockermeyer has already made at www.ketoforcancer.net. That's right, when you buy our books, you're not just investing in your own knowledge, you're also contributing to the future of cancer research. Help us make a difference. Together, we can drive change and save lives.
It's just like nuts. After a while, I say to myself, maybe I'm going insane. That you can see it's so clear if you understand what's going on. And yet I don't know what you have to do to change the system. But I'm telling you what you need to do. I'm telling you how you do it. I'm giving the hard scientific evidence to support what I'm saying in all the publications that we do. And you can see how many hundreds, thousands of people looking at our stuff. You can throw it up there and see how many thousands of views. I see, 85,000 people looked at my paper and yet did not make one single change in the clinic as the result of the information that I put out there. Now, what's going on with that? They're locked into the system. The system prevents them. There's a lot of very good physicians out there that would love to change this, but they can't do it. The system will not allow them to do it. So you have to change the system. How are you going to change the system, right? What's the way to change the system? Educate the people. They're the consumers. They're the ones who have to go down and get the treatments from the physicians at the oncology centers. If they say, I want metabolic therapy, and they say, well, we don't do that. Well, I'll go somewhere where I can get it done. Okay. So again, and also people have to they have to understand it's their soul, it's their survival. So it obviously means a lot. It should mean a lot to them. You think they would want to go out and learn as much as possible about this, so because it's their destiny that's under evaluation here. So yeah, there's a lot of things, but I keep, we get a lot of good support from private foundations and philanthropy. It keeps my lab going strong, so I can continue to publish these papers until I'm blue in the face. Eventually, somebody's going to look and say, yeah, these guys were right all the time. Why didn't we ever do that? And you say, yeah, well, we told you a long time ago how to manage this cancer, but you guys didn't want to take it up. So, but that's okay. We'll just keep pushing forward.
So that reminds me, everything you're saying, it's really hard for doctors sometimes, even if they want to do what you're showing through studies. Like, for example, the doctor that gave my dad the new Merck pill, Lagevrio, and Pfizer just came out with Pavlovit, I think. When you look at, if you just have to read the prescribing information, the insert that normally comes in the packaging, and you see that it's brand new. We don't know your short and long-term side effects. We don't even know if it's going to stop your COVID, start something else. We have no idea, but the doctors have to do it because these huge bodies like FDA, CDC, WHO, NIH say, this is what we're pushing now. And if you just open it and read it.
I can't speak for the drugs that are going to be used against COVID, because I haven't tested any of this and I know very little about that. But I mean, we certainly can know about the drugs for cancer. There's a lot of information on that. It's mostly incredible toxicity. But what your father is taking to manage COVID, I have no knowledge about that drug at all, and can't speak to it at all. or know what the adverse effects or the long-term consequences are of that.
But
I
what's
can,
interesting is when I ask my lung doctor friends, two of them who specialize in COVID, I say, how's COVID today? They say, basically nobody's dying. So why are people taking this experimental emergency use unapproved
yeah, well,
pill? Nobody's
that's
dying today, supposedly. I mean, I'm sure some still are.
that's a different question.
Yeah.
Why are you giving someone a drug that if they don't need it?
Yeah.
But that's, neither here nor there. But I focus mostly on the cancer problem. So I think if we can solve that problem, and I think we can, once people start understanding what the nature of the disease is, then I think we're going to make big breakthroughs. So I've always looked at cancer as it's very bright. If the future is, if once they change what the view of what the nature of the disease is and realize that it's a metabolic disease, then the approach to managing it becomes, wow, you can use a lot of different things that won't harm the person to manage the disease. So beautiful diet drug combos. Yeah, you're not going to get rid of it tomorrow, but by 6 or 8, 10 months down the road, you're back in top health again, and you have this thing under control. So this is the future, but Amalia, I have no idea when that's going to become standard of care. When I even wrote a paper, for glioblastoma, metabolic therapy, standard of care, metabolic therapy should be the standard of care for glioblastoma, but and for all cancers, as a matter of fact. But
See if
who
I can
knows?
find that one.
Yeah.
Is that the metabolic management of microenvironment, acidity and gluten?
No, that's the new one, but it covers the same stuff. We just published that just published a few weeks ago.
Is it the one ketogenic metabolic therapy? Because I do have a question about that. Can you tell us about foods? There are people that feel, they're going to get control of their stress or, God forbid, preventing cancer, being vegan. Some people now say, I want to be carnivore or ketogenic. Your paper right here that I have up on the screen says ketogenic metabolic therapy without chemo or radiation for the long-term management of basically glioblastoma. So what do you say in general for dangerous cancers or general cancers for food? Is it vegan? Is it meat? Is it keto, paleo?
Well, we use the glucose ketone index calculator, in which that patient, Pablo Kelly, who's on the web telling everybody how he survived 8 years with a glioblastoma. But he went into a carnivore. At first, he just did zero carbohydrate dieting, some small amount of fasting. Then he started to shift over more to a carnivore kind of diet. And he was taking various kinds of small supplements. But the bottom line was that he learned to manage his cancer. He never took radiation or chemo, which knocks the hell out of your body. And as I said, if the human brain should rarely, if ever, be irradiated. What are you doing to these poor people? So he chose not to do that. We can manage cancer without irradiating the brain. Once you shut off the blood vessels and starve the tumor cells of their glucose and glutamine, using the glucose ketone index calculator, which Pablo did. So every day he would take a prick of blood from his fingertip and then measure the glucose in his blood and measure the ketones in his blood, and you get a nice ratio. And the closer you could keep that ratio 1-to-1, the better you are in killing and suppressing the growth of those tumor cells. So he had a handle. He knew. And then what he did, he realized that, oh, my tumor is really under control. I'm out. I was supposed to be dead like 2 years ago, and here I'm still alive. His tumor was continuing to grow, but at a very, very slow pace. So then he said, okay, after 3 years, I'll have it cut out. At first, it was an inoperable brain cancer. And then all of a sudden, with 3 years of metabolic therapy, it became an operable tumor. So the neurosurgeon says, I can take this out. So they went in and took it out. And then he said, oh, now I should go back on but they never took it all out. There was always some remaining. So, and then all of a sudden he started like drifting off his rigid therapy. And then it started growing again. It put the fear of God back into him. So he went back down into the glucose ketone index calculator and learned to live with it. Now he's had a second debulking. It grows so slow. Glioblastoma grows so fast, usually kills you within a year or two. This guy's out 8 years, and the tumor, it's like he's learned to live with it. Every 3-4 years, he has a little piece of it taken out, but he should have been dead years ago. He has now 2 kids, and he's very happy with his life. but he's a little under some restriction here, but he knows what he needs to do. It's not like, and a lot of people are like this. They're just managing their cancer. They're learning to live with it. And then sometimes with the right drug diet combo, you can knock it out completely, that you're considered cancer free. But who knows? All I know is that the person is alive today that should have been dead a long time ago. And that's all we know. So we can't say the guy is cured. We can't say this. All we know is he's alive when 90% of the people with that cancer are dead. So, or more, but any event, yeah. So there's ways to do this. There's ways to manage this.
I know you got to go soon, so just a few more questions. I had Dr. Dannenberg. Do you want to get it real quick? We can pause. You need to get the call.
That's okay. I'll pick it up later.
Okay.
We get so many people emailing me for information, and I give them free information, kits, all the papers. They sit down with their family, and they discuss this information. At least it gives them the knowledge of an alternative approach, and they can do with it what they want. Every cancer patient should be fully aware of the nature of their condition, what should be done, and how to do it, and what are the options. I mean, that's all. And if you have the knowledge, then every family can make, and the patient can make their own choices as to the strategy they would like to use to manage their condition.
How do people get the kits?
They email me. And what I do is, and then there's at the end of the kit, there's if they want to make a donation to one of the foundations that supports our research, they can do that. So, and I just say, if you feel that the information in this kit helps you, you might want to make a donation. But if it doesn't help them, then I don't pressure anybody. I mean, if they feel that they've been helped, they can make a donation. If not, it's just up to them. But this is the situation. So anyway, yeah. So we do a lot of this, and I'm publishing papers but I also teach all the classes here at Boston College. We have a big classes that I teach. So it's an active participation in all these things.
I think it seems like I know a lot. I do know 3 people that died of glioblastoma multiforme, and there's quite a few in my life over the years that have lymphoma. So do you mind if I ask a question from one of my friends who's currently dealing with it?
Yeah.
Okay. If you specifically have swollen lymph nodes in the groin, what technique can be used to reduce them, even if they are 6 centimeters wide? Any techniques besides, because this is what she's been doing, besides eliminating processed sugar in foods, reducing all natural sugar in fruits, regular exercise, yoga, 8 to 10 hours of sleep daily, 1/2 of your body weight in ounces, prayer and positive thoughts. So she's saying, other than all that stuff she's doing, what do you have to say to people like that?
She's doing all that stuff right now?
Yeah.
Okay, then she should measure her glucose ketone index.
And how do people do that?
They buy you can go on Amazon and get the meter, the Keto Mojo meter.
Okay.
They have a couple of them there. You can buy, Keto Mojo is one of them. And then you prick your finger like a diabetic would, and you get a drop of blood. And then you can take the little ketone stick or the glucose stick, and you can get your glucose blood sugar, and you can get your blood ketone value. And then the meter will immediately calculate your glucose ketone index. And you look at the number. And if the number is low, like 2.0 or below, then you're in this state of therapeutic ketosis. And then you, at least you're there. Then you can discuss that with your oncologist or your physician and see whether or not you can add on some other minor drugs, like perhaps a parasite medication or some of these other things, and see whether or not the lumps go down, the swollen gland or lymph nodes go down. So a lot of people with prostate cancer can do this because they can get a diagnosis of prostate cancer with a high PSA, and then they go like Guy Tannenbaum. Then you go on these metabolic approaches, and it goes down to almost 0. So what happened? They were going to rip this guy's prostate out and do all kinds of mutilation stuff, and it didn't need to do it at all. So any event, yeah. So there's a lot of things you can do, but you have to have the tools and the knowledge to do this. And so the glucose ketone index is the way to at least know what the metabolic state of your body is.
I have about 2 more questions. One is the sun. Does the sun cause cancer? And can you tell us about melanomas?
Well, melanoma is a cancer of the melanocyte in your skin. And, you know, I mean, sun exposure can certainly put you at risk, I think. But sun is good for you as well. So, I can only say that it's no different from any other cancer, and you need to target glucose and glutamine to keep it under control.
Okay. Okay, that's good to know. So it sounds like overall people do have some control of what's going on, and they don't necessarily have to just jump right into all these therapies that hospitals and doctors are offering. So I really like that. I'm trying to think if there's anything else. I did have one other question. Sometimes I see people, they look so healthy, and I don't know, I haven't asked a doctor this before. They'll have this belly that look like they swallowed like 4 basketballs, and they look so healthy. I can see them exercising, or I'm like, is this alcohol? Is this inflammation? Why do some people have this huge healthy body, but then this huge belly?
Well, I don't know if you want to call it that. If the body is that healthy, you won't have that belly.
True. They look thin, but then they've got this hard looking belly. What is it?
Yeah, well, that's, some of that could be metabolic syndrome, which is definitely not part of being healthy. But again, you can't, if people do exercise, that's one way to stay into a healthier state. Get their blood ketones up and their glucose down. Water only fasting does that. You can really get it. Dominic D'Agostino, expert on doing all this kind of stuff. So yeah, he does it all. He's always in ketosis. If Dominic ever gets cancer, I'm going to be really surprised.
Yeah.
If everybody go out, look up Dominic D'Agostino.
Yeah,
He's a very healthy guy. He's always in ketosis, works out all the time, very fit guy. So doesn't eat any highly processed carbohydrates. So but he's healthy. And
I noticed he's on one of your studies. Let's see which one.
Yeah,
was
he's on several of our papers. He's on a Press Pulse paper, and he's on.
Oh, Press Pulse. Yeah.
He
There he is, Dominic D'Agostino. Okay.
Yeah, Dom D'Agostino. He's a very healthy guy. So he does not have his stomach does not look like he swallowed basketballs.
So I think my last question has to do with inflammation. Someone asked about if you know Dr. Terry Walls and the Walls protocol, because she did a TED talk maybe 10, 11 years ago that she had multiple sclerosis. And I believe her basic story is she was vegan, very plant-based, very healthy, but somehow she discovered on her own, she eats liver once a week, no more than 6 to 8 ounces. She eats grass-fed beef every day and certain particular specific carbohydrates, which I don't know. What do you think of just general information for multiple sclerosis or even bipolar schizophrenia? I think my question is just about general information.
I can't.
Her protocol.
Yeah, well, I can't speak to that. A bipolar disease or any of these kinds of things. There are reports in the scientific literature that diet and lifestyle issues can impact either positively or negatively on these particular conditions. So, but again, they involve some level of inflammation, and the metabolic approach reduces inflammation. But I can't say that a metabolic approach that we use for cancer would have an impact on bipolar disease or multiple sclerosis.
Okay. It seems like a similar story. That's why I asked that these people are typically going keto when they have those issues. I just want to say a little bit more about the professor, doctor, before we go, because his background is so amazing. Like I said, he was even served in Vietnam. He was a postdoctoral fellow in the Department of Neurology at the Yale University School of Medicine, and then served on the faculty as assistant professor in neurology. Other awards and honors have come from such diverse organizations as the American Oil Chemist Society, the National Institute of Health, the American Society of Neurochemistry, and the Ketogenic Diet Special Interest Group of the American Epilepsy Society. Dr. Seyfried previously served as chair, scientific advisory committee for the National Tay-Sachs and Allied Disease Association. He's received lifetime achievement awards from the Academy of Complementary and Integrative Medicine, the Internal Dose Response Society, the Uncompromising Science Award from the American College of Nutrition for his work on cancer. He presently serves on several editorial boards, including those for nutrition and metabolism, neurochemical research, the Journal of Lipid Research, ASN Neuro, where he is a senior editor. Dr. Seyfried has over 200 peer-reviewed publications, is the author of the book Cancer as a Metabolic Disease on the Origin, Management, and Prevention of Cancer, Wiley Press. By the way, you'll see the book is kind of high price for a book, but that's why it has so much information, and it's the very classic Wiley Press. That's why his book was recently translated into Chinese and is now under contract for translation in Turkish, and his full list of peer-reviewed publications can be found on PubMed. So I just had to say that because you just need to know he has done so much and so accomplished. Anything else you want to teach us before we go?
No, I think I've covered. I'd be happy to answer any questions that people may have, because a lot of this stuff is just so new. And when people hear it for the first time, they're like really overwhelmed, and sometimes just are amazed that all of this could be there and they never heard of it. And they get this franchise when they go and ask their oncologist, about this. They get very frustrated and they say, "Oh, no, everything that I'm saying, none of this exists and it's not been proven or evaluated." And then the poor patient doesn't know what to think. And it's very frustrating, because they should know about it and they should have an understanding, at least of best they can. So I try to publish as much of this in open access journals as I've already indicated, that at least gives them a chance to read it. And I think that's the best we can do at this time until the system changes. And it will change. I just don't know when that's going to happen, because the current system is not working.
Yeah. And it's interesting, you said the acronym of quite a few times, standard of care today for cancer. It's the acronym SOC. So sometimes maybe we need to stick a sock in it, because they're doing the same thing over and over when they just need to try something else.
I never heard it that way, but I guess it could be.
Read Professor's book and read his articles, and then we'll have more answers, and you can, maybe these people can pull the sock out of their mouth and we can learn a lot more.
Yeah, maybe that's a good plan.
Yeah. Thank God you're able to speak freely, and not every doctor can do that. So
well, I don't treat patients. You got to remember, I'm not a physician. I can't treat patients. I can't tell anybody what to do or what not to do. All I can do is give them the information, and then they would discuss it with their physicians.
Well, we appreciate you. Thank you so much, Professor Doctor. And thank you everyone for being here.